maybe months and maybe more than years, fused knees, severe valgus, huge bone defects. You have to do a lot of bone dissection, a lot of soft tissue releases. So once our surgical trauma is more, we expect a little bit slower recovery. All those patients who have a very minor involvement, we call in whenever we get such a patient with only mild varus, only no deformity, mild varus, only advanced arthritis. What do we tell our younger colleagues? Okay, today we have a British knee. Okay, you go ahead. I'm going and having a coffee, and it's better that you. So, those are the kind. So those patients obviously become ready to go home by second or third day. But majority of our cases are severe deformities. So, there is a difference in the basic demographics. So, anesthetic techniques, post-operative analgesia, comparison cannot do it.
So, from what we understand, one important thing is for a good outcome, the active mobilization of the patient is very vital. And this has been proven to two things: transarterial pump, if it becomes active in the initial phase, which is done by the active movements, are supposed to preserve the synovial hydration and the synovial blood supply, and the fibroadhesions do not take place. So that's very vital. And one other take-home message is no passive movements, active movements have to be done on your patient. And coming to the pertinent question which we saw in this India, where you don't have the availability of the gadgets, the advanced gadgets for all our patients like electronic infusion pumps, it becomes pertinent that you rely on something else which could be helpful to the patient, the continuous infusion. So how many of you here use elastomeric pumps? Oh, that's excellent. So still a large number do not use elastomeric pumps, and I think it was evident from the answers that you got. Elastomeric pumps have been one which could be used for all of you because it's bought by the patient, it is disposable, does not give an alarm, easily filled in, continuous infusion, and then there is no major disadvantages of using. So it's better than not using, but it's better than giving intermittent bolus where you can produce the level which is not maintained continuously like in continuous infusion. So intermittent bolus also has got the disadvantage of pressures falling down when you inject the drug. So continuous infusion seems to be good, and I also saw surprisingly a lot of people use multifusers because as it is 5 ml per hour is the standard one, but sometimes you require about 6 to 8 ml of the drug to be given. So multifuser seems to be a good answer, and fortunately I think Baxter has got both multifusers and unifusers, and I think that's a good one to use. I think we have, you want to comment on that?
Yeah, I've been using these elastomeric pumps both for periarticular infusions as well as for peripheral nerve blocks. When it comes to peripheral nerve blocks, I would like a bolus capacity, including the adductor canal block. When it comes to the periarticular soft tissue infusions, I don't need a bolus. And it works very well in both of them. The one major advantage to elastomeric pumps, my nurses love it, number one. Second thing is, you don't have a heavy equipment attached to the patient. If they can carry it on their shoulder and they can do all their physiotherapy instead of tagging along another big IV pole mounted pump. So those are the specific advantages. Last but not the least, we get a lot of MRSA and VRE cross-contamination. C deficit is common in Canadian hospitals, and we watch out like crazy. We have rules. Everybody who enters the room has an alcohol wash of their hand. When they come out, they have to wash again. We are not allowed to go from one patient to the other without alcohol wash of the hand. Okay? So that means we are really worried about cross-contamination. These elastomeric pumps is the solution to that. We use reusable pumps, and I'm sure they are not clean between patients in my mind. So on that account, that has specific advantage. We are trying to introduce it, but the cost in our system is for the hospital prohibitive, they say, but one of these days they will agree to that.
Yeah, thank you very much, Madam. And I share the same viewpoint, and we have been using elastomeric pumps. In fact, I hardly do cases under spinal in a high volume unit when you do a lot of lower limb procedures, and if you want to give a VAS score of less than 3 for most of your patients, it's a very, very ideal to put a continuous elastomeric infusion pumps. Really, really, you would see a huge difference in the compliance of the patient and the postoperative pain. So, not because the Baxter is sponsoring the session, but honestly, It's one way in India when the hospital admin doesn't buy you enough number of equipment like the continuous electronic infusion pumps. It's a very good idea to go for elastomeric pumps because it's proven efficacy and safety. Now with the advent of the regional techniques, when do you think using adductor canal block alone, you give a spinal and then giving adductor canal block alone would take care of the post-operative analgesia, or you would, what's your opinion on this?
I would say no. Yeah, it is one component that provides analgesia without producing major quad weakness. We don't use it in isolation. We always use that IPAC that Dr. Sinha talks about. We inject posteriorly. And I also do a lateral femoral cutaneous simple shock block. Plus, when we do the adductor canal catheter, there is an intermediate cutaneous nerve of thigh which travels along with the nerve to vastus media and is to supply the knee. You can identify it ultrasonographically. So as I go in, I will deliver about 5 cc's through the intermediate cutaneous nerve, another 5 cc's into the sartorius where the second branch travels, then go under the sartorius to put my catheter. And then we do the IPAC and the LFCN. That provides good quality analgesia for 24 hours. And then they will break through with the posterior knee pain. Posterior knee pain is a genuine concern. Unless you go specifically ask, they will give you a pain score of 8 out of 10. Ask them, where are you hurting? Are you hurting in the front of the knee? They will say, no, it's all at the back of the knee. So that is why I think the wound infusions probably in that area is a useful paradigm. But I can't have too many catheters near the freshly implanted joint. I will be out of my job. Yes, it produces reasonable analgesia, but it's not perfect.
Do you give an additional tibial nerve block along with the adductor canal?
If I'm using the posterior knee infiltration, which will be with a cocktail, we call it, we use a mixture of ropivacaine, morphine, ketorolac, and epinephrine. If I use that mixture for the posterior knee infiltration, I won't use the tibial nerve block. Sometimes my fellows will want to try it out just for fun to see does it provide longer analgesia. So some of them do it actually.
So now, from whatever we gathered, we have also found out that internationally we are not giving adequate pain relief. So one last question to all the panelists. Any newer trends in management that you wanted to share with us in giving good pain relief to our patients?
One of the major that we did, we were goofs actually. So in the hospital we provide fantastic analgesia. We forget about giving them the adequate prescription and instructions when the patients went home. That I think amounts to battery. We cannot do that. Post-operative pain doesn't stop when we discharge patients home. So make sure we order adequate post-op analgesia. The second component to all this is patient education. And I find the earlier they walk, the less pain they have is what we have found. If I didn't ambulate them on the day of surgery, those patients have much more pain post-operatively. I don't know what it is. Maybe we are removing all the mal substances, inflammatory responders once you put the patient to exercise. So they have much less pain once ambulated on the day of surgery. And you may give them drugs and exercises till cows come home. But unless you have a critical pathway of recovery and everybody buys into that, your early recovery discharge will not work. So you've got to have the physiotherapist, the floor nurses, home care, and the surgeon, everybody who is bought into it, including people who look after blood conservation and blood transfusion. So in our hospital, the whole team kind of pounces on them in the pre-admit clinic, and they are on it even after they go home. We have an acute pain nurse practitioner who call them daily to make sure they are maintaining their analgesia.
Dr. Kaka, you would like to add something on this?
Well, I think, as I said before, it's an evolving process, but two important aspects which she just highlighted. Patient education has to begin before patient comes on the operating list. That has to start in the OPD. That's a very important aspect. Post-op analgesia, they have to be told that this will be required for 6 to 8 weeks. There will be physiotherapy element. The reason I say this 6 to 8 weeks, though it is required, but in our scenario it gets extended. Because TKRs in our country are having about 1 week to 8 days package, in sharp contrast to 48 hours package. Well, I also want to say that post-op analgesia will continue to evolve. The exact technique has not yet come in. It's going to continue to evolve. Most of us are not practicing nerve blocks as yet. We're talking about adductor canal block, which is basically a sensory block, and you're going to need ultrasound guided blocks with that. This process is an evolving process, and where this evolution will lead, time alone will tell, because what we started to use for analgesia, for TKRs, 10 years back and what we are today, there is a huge change in the management of ours as well as the technique of the surgeon. So I think this evolution will continue for some more time.
Thank you, sir. Dr. Lobani, you wanted to?
I think I have a lot to add. Apart from the drugs used to for the post-operative analgesia, there are a lot of adjuvants which help beyond 48 to 72 hours. First 48 to 72 hours we are largely dependent on drugs for the perioperative analgesia. But beyond that, because we have been following up patients for a long time later on. So there are few elements which we make sure that patients should be following. One of them is a cryotherapy. We always advocate cold packs around the surgical sites for at least 4 to 6 weeks post-operatively, and to be done repeated every 3 hours, 3 to 4 hours. That means 5 to 6 times in a day while the patient is awake. The second thing is biofeedback therapy. We always tell the patients, once the dressing is done, they have a small dressing pad around the surgical site. We always tell the patient to keep touching the area around the knee with their hands, provided their hands are reasonably clean. So we ask them to put deep touch around the skin of the knee and do light tapping of the area around the knee. This gives repetitive stimulus around the knee to the brain, and the brain easily gets back to a normal sensation. Otherwise, usually there is a hypersensitization of the skin area around any surgical site, because the brain is under a constant threat that it should not be touched. A bed sheet should not touch it, a pillow should not touch it. So patients can't even get a comfortable sleep. So if they are repetitively touching it, so brain gets used to a new surgical site very soon, and the knee starts feeling normal much sooner. So we usually, this is one step to reach what you call a mission forgotten knee. The patients who have got a forgotten knee, they don't even remember they had a knee operated. So they are less sensitive about a surgical site. So this biofeedback therapy really helps. Third thing which we teach ourselves and through our physiotherapists is a reciprocal inhibition technique. It's basically a phenomenon in which any group of muscle which is in spasm, it can immediately be relaxed by making its antagonist muscle to contract against resistance. For example, patients have got a quadriceps arthrotomy done. Everyone has got. And the quads is usually in spasm in the first few days after surgery. So patients have an elephant type of a gait because they're not relaxing their quadriceps enough in the gait cycle. So we teach them hamstring contraction against resistance. The patients who are contracting the quadriceps are having very painful knee bending. Once we do it, immediately patient relaxes the quadriceps. It's automatic, and patient is able to do the knee bending comfortably, and patient has a more natural gait. And last but not least, there is a good role of assessing the personality of the patient, advocating anti-anxiety drug and antidepressant drugs, and ensuring a good sleep. Patients who have not had a good sleep almost always will end up in a chronic regional pain syndrome.
So thank you very much. I think we had a lovely session. Now we are going straight to Madam giving the Dr. Ravindra Bhatt Memorial Oration in the main hall. I take the opportunity to thank Baxter for organizing this one, and the voting pad showed the clarity of your thoughts on what you are using, and the expert panel for sharing their thoughts with us. Thank you very much, and I request you all in the main hall now. Thank you.
Thank you, sir. I'll request the audience two keypads are still amongst the audience. So may I please request you to kindly hand it over to us before you leave.
ultrasound machine and I'm just thinking of a person with periphery, if he does not own ultrasound machine, he feels probably something grossly he is missing. We started our own nerve blocks with the paresthetic technique for our own post-graduate days, and now we say without ultrasound if you're doing it, something with the peripheral. So much with peripheral nerve stimulation also, we say, well, it's still not optimum. We should fit that also. That's what my friend Ravi says. Well, the whole idea is, if you're talking imaging facility as a whole idea is a visualization. That's both thing, accuracy. What paresthesia was, that was confirmed, say this is a live wire, that was a nerve. And you say fluoroscopy, we could anatomically configure the two-dimensional view, say one pole overlap, this is view, this is transforamen, this is vertebral body foramen, all those things. But again, you're missing soft tissue. Then you have the CT guided, whatever interventions and all, you can compare both bone landmarks and soft tissue. And secondly, somewhere a story came, the radiation exposure. For its own interventions. So again, we are looking at ultrasound sonogram, by any chance it can make a difference. Does it make a difference? If it can make a difference, what difference can it make? And if something is good, there are some limiting factor also. And what are those things? Can you overcome those things? The whole idea is this is ultrasound, whole thing is being for accuracy, expression, safety, direct information. Biggest problem is we are also low adopter. We find it very difficult to change. To change from it, I should say, the way you're buying a private ticket from the counter versus online booking, we took quite some time. Even ask your own parents now, they feel comfortable going to the bank, filling a withdrawal form, collecting money rather than asking you the ATM card. So basically the tendency there within all of us is the comfort service landmarks, but of course technical acquisition cost and learning curve are the main limiting factors. The advantage of ultrasonogram are it provides direct visual soft tissue, there's no doubt about that. Provides real-time needle advancement, which fluoroscopy because of the radiation risk of exposure. The risk of radiation avoided, of course, machine is transportable, but fluoroscopy is quite bulky. The ultrasound machine can be transported. The cost is comparable, can be used for the specialty work, but last time I would like to cut it in half with other specialty part. I want to take it up, make it more exclusive for yourselves because you are running enough money for your system. Okay? No more piggybacking of all these things. But well, if there are advantages, there has some disadvantages or limitations. We're talking current status of ultrasonogram. What exactly, where does it stand in the chronic pain, especially with the back pain? It is dependent on observer. In fluoroscopy, we get a static still picture. I can show it, but here, the probe, it's until Krishna. He holds the chariot, he can twist the whole chariot whichever he wants. Other chariot may not be able to follow. Not even Arjuna. So it's dependent entirely so much on that. One hand is held up in the probe. In the fluoroscopy, we have both hands free. Right? And what you are getting in bony details obscure the information, and this is what I'm trying to say about it. In fluoroscopy, bone is a friend. You touch the bone, you know you're safe. But here, once you touch the bone, you lost the trajectory. And of course, there is contrast spread. That's one thing. We can't see the contrast spread so clearly, whatever we can see in probably in fluoroscopy. And also intravascular injection, same issues. And biggest thing probably what disturbs most of us is technical angle from the conventional orthodox way we have learned in the last 2 decades and all, sterility. With the probe and all coming, walking into our area and all, where you're doing absolute sterility, we find slightly disturbing. But if you do laparoscopy surgeons taking the camera and all, then you start adjusting, okay, it may not be that problematic, maybe if there's a will, there's a way out. Okay? Now, learning curve is always there for everything. I won't say anything short and brief for that one. Of course, central blocks, I don't talk about it, it's not part of the topic. But most important is the poor resolution of parameters. That also has been overcome. Probably some magnetism, something new, which is saying something, E-zone or something new device was come where your magnetism needed to visualization improves. There are numerous things which are coming up. Now, well, in today's session, what are the 20 minutes we have good debate about these issues. Are we getting carried away with a new tool in our hand? It's something like for the first time I give my child a hammer and a nail and she's looking at a wall. Which wall should I hit this nail? Are we getting carried away? Is it so? If not, it's going to add to the cost of treatment. And if you ask me, no. Does it really make a difference? It does. It does. It makes it because it gives you office-based procedure and probably less radiation, less cumbersome. Probably have more amount of freedom as you can do about it. And look at how much if you want to go use a fluoroscopy, the lead and all those things, quite a bit of thing comes out. Or the next question, if that is the case, is it only a mental block of not willing to change the way we are doing? Or looking for a reason? But one thing I was just telling my friend, the whole ultrasound starts after 6 centimeters, especially in spine. The story starts at 6 months. That's where the spine elements, all those things come up. The wings, the cap, the tail, everything comes up. Then you start losing anatomy. Till that time, everything is up to 6 centimeters, everything is safe in life, but problem starts after that. And next, if that's the case, any modification which is going to make it more acceptable. Is it happening? If it's happening, what are the things that are happening? The most of this is the most limiting factor. Last one is most publications are in the last few years are coming out of few centers and few experienced pain physicians. If you just look at the amount of literature which is coming, it's a few pain physicians and few centers, and it's something is going on like that. But of course, there has to beginning, and that's what you're going to see over here. So this is one of the ferocious tribe of Masai Mara, the Mara tribe, very violent. They're so secluded, you can't even just try to enter the jungle, they'll just kill you. They'll make you feed for the lions. If they are also willing to play for Kenya, the cricket, I think we should also have some. We can make an attempt, why not? Coming to the USG for intervention for back pain, the ultrasound faces unique challenges in spine injections where most of intervention require use of fluoroscopy at this stage. It's been compared. The most of studies I would like to say just go into Cochrane study and all. Unfortunately, your studies also compare ultrasound with CT scan. Often you take a patient for facet joint injection or middle band block to CT scan and say gradation in CT scan is much higher compared to ultrasound. Compare a horse with a horse. Why don't compare a horse with an elephant? And say the elephant is slow mover. Not the way. And provide, only thing is ultrasound provide good visualization of bony surfaces which makes it useful for superficial spine injections and make it very clear point. Ultrasound provides good visualization of bony surfaces which make it useful for superficial spine injections such as middle branch, facet intraarticular injections, trigger point, of course intraarticular region you don't do it, trigger points, caudal injections, piriformis injection and essential injections. Look at the next paragraph, totally contrast. The 6 centimeter story. Deeper spine interventions are difficult because of limited resolution in the presence of bony artifacts. The bony surface is uneven. Accordingly, spread of injected in epidural space and intracranial with ultrasound alone is not possible. It needs assistance of one more. Could be DSA or could be fluoroscope. That is the current status as you see over here. And of course, these are the views what you keep on seeing. The lumbar puncture came out 1971, technology development. The curved area of USG probe of low frequency 2 to 5 MHz. 7 to 8 cm depth. Beyond that, the story stops there. The parameter says that these are the views which normally people keep using when they do the spine roll. Some of the correlations, the interventions, what I'm trying to say about this picture, if you just look at Francis' picture, of course, people regularly know it, nothing special. But I wanted to give like that, if you see the spinal cord, and what happened, all the posterior elements look like one white line, and all the angles look like one more white line. You don't have anything in between. That's one technical problem, what you're going to see. And there's probably about 6 or 7 interventions which probably most of people are doing the evidence. Little bit evidence is available of plus or minus, but one of them is lumbar middle branch block. Look at the study which has come to for you are the man who discovered the ultrasound guided lumbar middle branch block in 2004. 25 read the study, so beautiful. 25 of 28 needle placements accurate compared to fluoroscopy, not 28 out of 28. Right? And similar to see, they said non-randomized crossover trial with USG fluoroscopy 28 patients able to place the needle 95% of the time. Okay, the limitations is the weight of the patient was 51 kgs. I repeat. Now your patient who requires middle branch block, most of them will be weighing above 70 kgs with a degenerative spine, with listhesis, some scoliotics, some kyphotic, with all the facets and all osteophytes there. So it's basically trying to sell a product, beauty product, showing a beautiful model, but when the cosmetic powder has to be in somebody who is totally distorted. So that's a technical thing what you have to understand. Thin needle is a 51 kg, ultrasound could not detect intravenous injection in 2 patients. Small study of about 28 patients. Of course, first view what we keep seeing, look at the facet joint injection. This is a report the feasibility of ultrasound guided facet joints in 2007, 40 patients. Again, look at the statements. Reported success rate of 94%. That is 17 out of 18 needles within 5 millimeters of visualized facet joints. 5 millimeters, not into facet joint. Okay? Now, actually, technique comes 18 of the debate, 17 or 20. The issue being the higher body mass index, same weight. It was 100% fluoroscopy and CT. If you feel the 5 mm correction acceptable, yes. If you feel, of course, first of all, we are not a pressure joint injection, different story. But of course, we have limitations. Maybe some technology might come, something might improve. With the current information, this will be standing. This is again Dr. resistor water control tile of 2012. You can see this one. USG guide was CT control pressure joint injection. This is what I'm trying to say. It's not USG versus fluoroscopy. It's CT guided. Prospective oscillator 40 patient. USG need analysis through respect to segmental internal ligament. Needle position confirmed the CT accuracy 90%. Again, compare last one is time and radiation. The time taken is of course CT versus ultrasound and radiation. Of course, ultrasound will not be radiation, so automatically we tend to say CT definitely. But CT is not a standard practice of pressure joint injection as we develop block. Lumbar root block, of course, we will not debate about that one. It was described before in cadavers as periradical injections. Again, this is beyond 6 centimeters. Depth and presence of bony structures of different contours. This is a beautiful statement. The whole problem, if you want to do a transferon injections are beyond 6 centimeter interventions, the story starts with depth and presence of bony structures of different contours in lumbar spine, obscuring visualization of target structures in the neural foramen. This is where you get stuck. And probably because you try for too long a time, you think, okay, this might be, you might be doing it, it might be just a periradical injection, it may not be a conventional transferon injections. That becomes the limiting factor. So the question here is, then you start believing, let me do a rule of 3 injections. After 3 injections, you will become alright. If you have fluoroscopy, if you are able to confirm, why do you want to kill snake 3 times? Why can't you kill it first time? It's because the first time I could not reach the target, I am taking by chance of another 2, increasing my chance of success. But well, technology might come at some tool which might explain this thing. But one thing is, as one cannot accurately deal in the lumbar root in ultrasound, the process is essentially the same as paravertebral injections. So that is where the whole thing comes. And of course, pararadical injection for LLD, again, this is Cochrane trial 2014. USG CT control, again, same story, CT control here. Prospective was a 40 patient. Need advance of all this ligament. Again, comparison was time and radiation. It's not fluoroscopy. So piriform muscle injection, yes, if you ask me, yes, is one good tool. Poly test doesn't make difference. Poly compared to fluoroscopy because you can see soft tissue, you can represent the muscle. And most of our people are doing it's an office-based procedure. Relation to sciatica can define trigger point in muscle. It definitely is good. Yes, there could be some technical difficulties, obvious engagements and altered anatomy. That part is always about 10% population always there. This soft tissue not an issue. Always. Others, what was the better option we had? We are using fluoroscopy. Definitely this adds some more definitely comfort zone. So a picture of the piriform injection over there. Again, same thing, why not transferable by ultrasound? What are the limitations? The major complication population is something. Cervical transfer, the one of major complication has been death. Talk of when paraplegic lumbar. Okay? Discussion of mechanism, intravascular injection and of corticosteroid is an issue. The last one, too dangerous use of ultrasound guidance. You cannot exclude intravascular injection because a radical artery cannot often be seen by Doppler ultrasound. So basically, there are do's and don'ts. Certain areas they are being as permission. Certain they are not being as permission. Different level of what evidence is there. If that is the case, what is the level of evidence? Leave the talk about peripheral structure. This was published in the should say the regional anesthesia pain medicine 2001, supported by the you can say American Society, European Society, and Asian National Society. All 3 are there. These are the peripheral structures, axial structures of musculoskeletal. Of course, our area of interest, low back pain comes in axial structure. Level 1 is sacral joint injection, that is pediatric injection, not into the joint. I make it very clear. Level pediatric, caudal sacral foramen come under level 1. Level 2 will come for us technical lumbar medial branch block, lumbar facet pediatric block, and interlaminar epidural. And the show stops there. So technical we have 1, 2, 3, maybe 4, 5, 6, not more than that for the back pain. There is some amount of evidence or some amount of competency there. If this was the recommendation of all the societies, what is the recommendation of IASP, one of all pain bodies in the world? Level 1, let's look hierarchy of USG guided procedures, IASP recommendations. Level 1, conclusive preclinical validation, standard imaging and dissection and clinical research, performance of peripheral nerve blocks, following trigger point injections. Level 2, strong research-based evidence, that is television block. We do agree, the software is definitely much superior compared to anything. Level 3 is limited, feasibility study, a preclinical or retrospective clinical study, interpersonal blocks, to such kind what is branch block or phase joint injections. Level 4, most important, indeterminate case report, expert opinion, please do not start. So to sum up, I would like to say current evidence says in level 1, Definitely you can go for the low back pain, whatever interventions are. These are things which are level 1 and 2. Level 1 is SHA periodic level, caudal cycle foramen trigger point injections. Level 2 is lumbar medial branch block. Level again lumbar facial periodic level, inclinal epidural. Level 3 is that is definitely please not to be attempted at this stage unless you're an expert in that area is deeper spine interventions beyond 6 centimeters. Unless you have the skill, knowledge, comfort zone, please do not venture into the area. Don't try to become Abhimanyu. So you are the first person to transfer in India by doing this, not at this stage unless you're an expert. So to conclude, I would like to say the technology is here to stay. Whether you like it or don't like it, the mobile is going to be here, laptop is going to be here, maybe in different fashion. Radiation safety definitely is a concern. Definitely we should think whether ultrasound can offer. But only thing is, some starters and you want to buy ultrasound machine also fluoroscopic might be a tough call. For all institutions which have got both the things, you can start adopting to either of them, limit the radiation and offer more accurate soft tissues. Soft tissue of course is uncomparable. Practice makes people touch perfection. Still a lot of physical studies are going on, require more RCT to really say that we can go over it. Gray areas need to be addressed, of course. Most important thing is more skill and experience is awaited. I think I stopped with this one more beautiful picture. I liked it so much. And I think Sandeep also agreed. This is again one of the pictures from Masai Mara tribe. They wanted to play billiards desperately. Look at their billiards board. Just to say where there's a way out. It's just a question we had to apply your task. And thank you one and all. Thank you so much.
Question answer session. Yes. Thank you, Dr. Joshi. Our next presentation is on. Sorry. Our next presentation is on evidence, radio frequency ablation in chronic back pain by Dr. Neeraj, who is a senior consultant, spine and pain specialist with Max People in Delhi. May I invite you, sir?
Yeah, that's fine. First chairperson sitting here, Dr. Jika, batchmates, Dr. Deep and Chaudhary. Again, I thank the organizers calling me for the talk. There was positive time, but I'm lucky that there is a little more time with me, so I might extend a little further. So thanks again. We're going to talk about RF for chronic back pain. Now, why it's so important to talk about this topic? There's one reason, because the prevalence of chronic back pain in the society is to the tune of 20% given time and 80% lifetime. So, and it's so nagging that it really kills patient out of all this phenomena, be social, personal, financial issues. So it's so important. You see the spine people, you realize how important it is to address this issue. So how effectively we can do it, we'll try to do justice as well as possible. Well, it's come a long way. It's been pain management of 18th century, we'd rather call it butchery. And I always say the advances in surgery is parallel to the advances in anesthesia. And they should really be thankful to all anesthesiologists who have made the surgery safer and advanced further. In the meantime, the anesthesia also advanced to the tune that we have gone into the advanced pain therapies, and we see all this thing happening day in, day out, vertical palms and spinal cord stimulators. That's the domain of the interventional pain specialist, which very much 80% anesthesiologists all over the world, by the way. This slide is just for the fun sake. You know, normally the anesthesiologist has been taken as a coffee guy in the side room or pre-op room, but things have changed, model has changed, and they're almost the center stage of the whole hospital. Be it intensive care unit, critical units, be it operation theatres, be it the emergency rooms, or the bigger role coming up with the chronic pain management, chronic pain specialists, doing justice as a primary care physicians. Yeah, this is a new language. We really have to learn it. Adaptive minds learn it faster, and I always advanced can take it early, easier and earlier. It's always better they can make most use of their life doing this justice again. Chronic back pain when patients fire. I told you, it really kills in many dimensions, and they keep playing with the painkillers. He keeps saying, these people, they don't want surgery. It really happens. There's such a lot of surgery phobia around with spine surgeons. I know what they have been doing with all these patients, why such amount of surgery phobia. In good surgical hands, spine surgery could be safe. But the problem is, after all, it's a surgery, and there are surgical factors. Be it fibrosis or something, which is always there, you can't help it. Now the problem comes is they keep taking painkillers, and there are inherent dangers of painkillers. Half our dialysis units are filled with analgesic nephropathies, and quite a amount of massive GI hemorrhages are there because of the analgesics being taken by the patient from the chemist. They go to the chemist straight and take the analgesic, that's the worst part. Beyond the natural reasons of back pain, where gynecologists give a bigger help, we have other reasons for back pain, and let's celebrate one by one. I thought my previous speaker would have covered it, but I think probably I might have to take a little time on this, go through this. Well, it's mostly, we can say it's 30% discogenic and another 30%, 40% is a festal pain. We can call it festal syndrome also to some extent. There is the sacroiliitis, we all know about this. And then inflammatory spondylolisthesis or spondylitis. And then spondylosis and lysis, we know it is 1 to 2%. And infection of malignancies, we all know it about. In tuberculosis, pot spine being such common in India, I am very wary of this. When I do this procedure with steroid getting into the body, I am very wary of the tuberculosis if it comes in. Really have to be treated, and it's become very intractable. I've had 2 patients who have been treated for tuberculosis later on. Then osteoporotic vertebral compression fracture. Osteoporosis per se without fracture also can be a chronic pain, and which has to be addressed just by aggressive mineralization therapy. In spite of doing all examination, all investigation, sometimes there's a diagnostic puzzle. You don't reach to the final conclusion. There are good number of patients in practice really realize you really can't pinpoint this one thing, and sometimes there's so many co-syndromes or so many comorbidities you can't say one is causing the problem. And many times they mimic each other. Be it facial syndrome, SI, radiculopathy, they really mimic some time and really have to go for a diagnostic block to have a diagnosis and proceed from there. Well, this is biomechanics of the spine. Why this slide? Because 80% of the weight is carried in the anterior pillar and 20% posterior pillar. Now what happens is when the anterior pillar doesn't work properly like with the degenerative disc disease, there's more load shifting onto the facet, and that's called a fiscal pain. And if it is chronified, it becomes a fiscal syndrome because you have a degeneration coming in now. We can have different stages of this disease, and we have to address them separately, as per the needs, the different treatment for different stages. And as like in some single patient, you can have all 3 or 4 kind of this disease. So you have multiple this disease, and you have to treat them in their own merit, as per the need. You have to tailor-made the treatment for each disc. That's so important actually. One has to realize the same treatment doesn't fit in all discs, But yes, you can treat all in one go. That's another important thing. Well, there is a radicular pain coming because of this. There's a disc protrusion which is compressing the root, be it central, paracentral, foraminal, or far lateral. And accordingly, there's a leg pain, which is radicular component, which is there along with the back pain. You have to address accordingly. Now, when there is only degenerative disc disease, there is no merit for surgery at all for these patients. But many times they keep suffering for years together because of chronic pain. And you just see the annular fissure right there. Right there, there's annular fissure, and that is causing pain, but there's no disc component coming out of this. The others 1 to 3 score pains. And what you have to do with these? And you can see annular fibers. There's 7 layers of annular fibers, and it is tearing from inside. First 2, 3 layers, there's no pain. But as soon as it starts reaching the outer layers, these are sensitive. The nerves are there in. And in fact, in chronic pain patients, they grow inside into the inner fibers also. And that causes the pain. Oh my dear friend. That is eventful. Okay, as it is era of least invasiveness, all can be addressed with the least invasiveness. This is what Dr. Chaudhary is looking for, the RF slides. Now the RF slide starts. That's the introduction part. Now, this is what is being done. We are putting a needle inside the disc right there, and these are special needles where the tips are RF. There are bare tips. You can put an RF to those needle tips. You can see those needle tips all these 2 places. What is being done? This is the very latest advancement. They're doing pulse radio frequency into the intradiscal area. What they do is they do a provocative or evocative discography first, find out which is the pathological disc, and accordingly do a pulse RF into that. But pulse RF, it has to be about 42 degrees for about 8 to 16 minutes, and that is done at the pathological disc. And that is how the radio frequency gives the lesion, it gives parallel to the shaft. So that's about the conventional lesion. And when you have to be a pulse RF, it is at the tip of the lesion, by the way. That is at the tip, right there. So if you have to do a, well, fine. If you have to do a pulse RF, then it is close to the tip. The nerve has to be lying close to the tip. And a conventional RF nerve has to be lying parallel to the shaft. It's so important to understand because needle tips have to be placed accordingly. Now this is about bioplasty. When monopolar RF, it does not really give very big results because that's because it is being done in the pulse RF. Some people have reported results, but better results are reported with the bioplasty, whereby two needles is like bipolar RF. We put right in the posterior 1/3 or up to the middle half of the disc, and we just do an RF there. We just do the needle placement in the posterior 1/3 to middle half, and we just do a bipolar. And this bipolar is done by cool RF up to the 55 degrees Celsius. Some protocol is there. So bipolar frequency electrodes are placed obliquely on the posterior little aspect of the anteroperty annulus. The Baileys are given this product, by the way, and it is gradually heated up to 55 degrees for over 11 minutes. Another 4 minutes of heating is given. And that in a way kind of contracts the tissue, stabilizes the tissue, and kind of does the neurolysis of the granular fibers, annular nerves. And that has given a very good result, although there are initial studies only. Another good thing which is there is a high frequency and radio frequency, and this has been done to seal. This is more like a sealing. We go into the posterior to the annulus and posterior annular fiber and then do a radio frequency, and that seals the defect. And that we conjoin with the all endoscopic or disc fix procedures. That's the best part. So when we do a debulking, then after we add this for the annular pain. Otherwise it was not addressed earlier. Very new development which has come in very recently. This is the fibrin glue. It is being used for posterior puncture headache. Now it is being used for sealing action at the posterior annular basis. And they have started using this, but it's still in initial stages to call it a day. Now, discogenic pain, many people say there's a visceral component to it. Now, sympathetic fibers, they supply the interior half of the disc, interior part of the disc, and that can be taken care only by the sympathetic components. We do a MI complicated disc radio frequency. Gives a very good result in intractable patients who are not responding otherwise. Sometimes even sympatholysis can be done. Now, few patients which I have seen, they got a very acute nagging aerodyne in the middle of the back, and it is not been responding to any treatment, and any investigation is negative, and the patient doesn't allow to touch the area. Now, there is a very trivial history of trauma in these patients. And it could be, I think it could be a kind of CRPS. People who are expert in the field, they must have seen this patient once in 6 months kind. And there we do sometimes sympatholysis. It does help these patients along with other treatments. Yes, ozone is calm. We try to combo these procedures. I always believe in like multimodal anesthesia. I do a multimodal therapy for these patients. We put a needle inside the disc, put in a little ozone. There are some papers already which is helping these patients, especially initial stages in contained disc. When there's a big disc, everything being done, debulking the disc, next thing you might have to do is just to open up the roots. Sometimes the neural foramen are still closed. What we do is we put in a catheter inside the area in the epidural space and reclaim our neural space. It's a very important. Until this reclaim neural space, it doesn't go by itself. Now, important thing in this slide is you're seeing those two needles inside the disc. They're doing the bipolar or bioplasty, and the other balloon is opening up the area. This can be done in foraminoplasty. This can be conjoined with the other procedures which you're doing interdiscally. And this is how the balloon lies, and it opens up the area. About 6 millimeters is a balloon size, which is a very good size opening up. Now, we do all this interdiscal procedure. We know all this L45 or L5S1, how the things are placed, how the needling has been done. I think probably people who are into pain practice, this is a very basic thing. And the scooty rod is very important in here. Actually, if my laser pointer would have been working, I would have shown you what procedures to be done at which level. But important is to understand this interdistal. We are avoiding nerves, but sometimes we have to get close to the nerve. We have to get next to the nerve when we have to do pulse RF or DRG. The important point here is you have to go a little more oblique. They will go most posterior to the dorsal root ganglion, and there you do, because DRG is the headquarters of the nociception. And that is where you put your RF tip and you do your stim, and accordingly you do your RF, pulse RF here, not the conventional one. And there are already RF catheters are already in market. They've been used epidurally, or surgeons are doing it for these reasons. And you can take it to catheter, stimulate the nerve, and do a RF there also of the DRG. There are so many papers, there's a whole lot of papers on how the radio frequency is helpful in chronic back pain, especially fistula pain or interdiscal pain for that matter. This is neuropathic spinal pain. and there have been some 28 patients, pulse RF has been done at a DRG, and the results are there, right there. So at 3 months is 23 of 8, 6 months 20 of 28, and 12 months 9 28 had some little pain relief. But at 1 month there was a moderate good pain relief at the DRG. That's pulse RF, by the way. Now, in spite of very good work being done by the surgeon, you see all those big implants all over, patient still is in pain. She needs help. What after surgery? That's itself is a big question. And there is no marital suffering. No surgery, but still patient has got a pain. Now, what all is this about? This is the facial pain. Look at the facial joints. Look at the normal facet up there in the right corner, and the lower ones is the bad facial joint. And all those osteoarthritis is bad facial joint, and the stenosis is there. We do intra-articular injection, we've been doing it. Now it's been done mostly for diagnostic purpose. Mostly we are doing radio frequency at the medium branch, and that is how the needle is in place in the intra-articular. And sometimes you see the facial arthrogram. Now, one important thing is you see the recess, superior and inferior recess of the facial joint here. And you have to put your needle right there in the inferior recess or superior recess if it doesn't allow in the middle of the joint. And you can still do your job. Another important slide in here is you see those big sunniversals there, which is the cause of pain. You have to go and address, you can do it from posterior. Look at this next slide. It has been put from the posterior and punctured the facial cyst and the sunniversal cyst for that matter. Well, some people have tried pulse RF at the joint also. I don't advocate, but still, just for sake of completion of the slides. Now, this is just to make you understand what is the anatomy, facial nerve anatomy. For given facet, you have to take the care of the nerve at the same level and one level above. Always remember, this is very important. 2 nerves supply same joint, and 1 nerve supplies 2 joints for that matter. Now, the point is, the most constant point is, remember, SL ligament, where the nerve passes by, and that is where you try to hit, because otherwise you might miss the nerve. That's so important to understand. The ISIN is given reasons. The single indication for lumbar radio frequency medium branching artery is completely opaque following the controlled diagnostic block of the targeted median branches. This is ICS guidelines, and these blocks may be placebo control blocks or comparative local anesthetic blocks for that matter. Other people who are very much into the evidences and all, this is another evidence. The American Society, Military Pain Society practice guidelines, individual techniques in the management of chronic spine pain, states the evidence for radio frequency neurotomy medium branches moderate to strong for short term and long term relief of lumbar and cervical facial joint, and was intermediate for the management of SI joint pain. The ASIPP guidelines recommend 3 months or longer between each procedure, provided more than 50% pain relief is obtained for 10 to 12 weeks, and that the therapeutic frequency should remain at the interval of at least 3 months for each lesion. So important. This for evidences, you know. Now, this is here the needle has to be placed. So for 2 joints, 3 needles have to be placed, as I mentioned you, and it has to be at the junction of the subarachnoid process, transverse process typically. And this is where you are trying to, you look at the nerve. The yellow is the nerve, and that is where your needle is staying parallel to the nerve. That's important for conventional RF. And this is the lateral view of the nerve, by the way. This is a put-up slide. And you can see again in the junction of the superior articular process, basal superior articular process. But don't go further because then you're going to meet the somatic nerve there and the roots. And this is where the whole parallel nerve, the yellow thing is now again. And yes, it failed back surgery syndrome, people already suffered. That is where score over the surgeons, because they can't go ahead and do all these facial pain procedures where you can always do anything, need be. And that is where another thing is, in a patient who has been under vertiplasty, has got a facial pain because of chain mechanics, you can always go and address this pain, facial pain, because patient is still complaining of pain. And now this time it's not osteoporotic fracture pain, remember. It's the facial pain, and you have to address facial pain now, and you can give relief to the patient. Before you start, some important slide for experts. Double check your equipments. Check installation of the RF needles, especially your people reusing their needles, by the way. The sensing pacemakers, you have to either understand the override or continuous ECG monitoring has to be done. The smart card stimulators, the risk of current divergence is there, so you have to turn off the stimulators before the procedure. The conclusive comments on the RF, by the way, is very efficacious for many chronic pain disorders. The success rate for lumbar median branch block varies 60 to 90%. The cervical region success is 71% was reported. The method was also good, has good results, 80% cervicogenic headache. Again, we do at C2 level, I'll show you some slides after this. 90% long-term success rate on DRG procedures or in herniated disc, and less incidence of complication compared to the other available modalities. It is definable, predictable, but it's still not without risk, and key therapeutic modality for modern pain practice by Schulzer was one of the stalwarts in the RF. The evidence of RF ablation, again, if you want to chart down for medium branch, There are different bodies who are giving different evidences. For cervical level is 2A to level 2.2, and lumbar is 2A to level 2.3, and the other criteria also probably is more of academic or theoretical purpose, but understanding is important, how far it is helping at which level. That's another important thing. In lumbar facet, randomized double trial was done, pulse RF versus sham versus CRF. What was found was pulse RF CRF was longer than the sham, and CRF was the longest, conventional RF was longest of all. In spondylitis or spondylosis or spondylodiscitis or spondylosis, when there is a dehiscence is there and patients complaining, many young people come down, young cricketers, they are coming to me, young boys, and they have this dehiscence, the lysis, and they keep complaining of pain. What you can do is you can put in RF needle, do an RF there, and do a distal RF also, medial branch RF also, to help these patients to some extent. But if it's a lot of distances, they have to be fixed, not to miss on that. Low back pain sometimes is still a puzzle in spite of everything being done, and sometimes it is seen it is sacroiliitis, which is 15% of the chronic back pain patients, be it coincidental with other diseases, as I told you, comorbidity. You have to address it, really test it clinically and by radiology, and then you do a diagnostic block and therapeutic, which is many way therapeutic, you are adding steroid to it. And that is where you are doing the SI joint block, and thereafter you do the ablation, RF ablation, although not strong evidences are there because there are so many nerves supplying the SI joint, hundreds of branches, but you can really take toll on the major ones, and that is where you do a 3 blocks at a given foramina, because S1, 2, 3 foramina are supplying along with L4 and L5 nerve, and you have to take care of all of them. That's where pool RF is a bigger help because it gives a bigger lesion. Right? You're looking for bigger lesion, you have to cover all these nerves. And that is how the needle look like. At the 3 o'clock, then you have to do one lesion at 1:30 and another lesion at 4:30. Both sides, if both sides involved or one side is involved. I sometimes do even in tubercular sacroiliitis pain. At least pain can be taken care as the treatment goes on. And this is the study done by Villaggio, and he found this a good result for 6 months down the line. He showed a good result with all these patients. But I would rather not advocate pulse RF in these situations. I would rather be happy doing a conventional RF. This is sometimes people do intra-articular also RF, especially the lower junction, because uppers are nicely taken care of. And this is the palisade. New thing has come in by Cosmin. There was a paper recently, and they could put multiple probes in there and they do bipolar between them. And that is, they have found a bigger success rate, putting all those needles put together and doing RF between them. This is the ganglion part block, tailbone pain. Many people have this, lower back. You may put one needle, you may put 2 needles inside. You do RF like in per block RF, and you come out and do RF. I have read one paper, nice paper of the coccygeal disc pain, and they did a RF of the coccygeal disc. Good paper, with good results. And when I come out, I put in my depot if need be, and do a RF. After that, if a patient is still intractable and doesn't find good relief and still needs a little more help, I do go and do a coccygeal RF bilaterally in such patients. Remember, it's such an important thing. Sometimes it's a bad patient, I combine first go itself. But he need not be sorry every time, because there are sometimes you still feel, in spite of very good work being done, still patient's pain. Now what we are missing is, sometimes I've seen, good number of patient has got a transition vertebra or something sacralization, lumbarization, and there's a bone fight. And now this is goes over decades, these patients. And I always, when I get my patient, I always ask them for X-ray. Although this is the least time we ask for, but it's so important to have an X-ray, and it's all the more important. That is where I put in my needle, do either my dipometrol, sometimes even finalize them, and if I feel so, I do even RF also, because I can always combine the RF with my chemical installation there, and it really helps these patients. Otherwise, nothing will help, and you have done all of the good disc procedures, still they are in trouble. This is about cervical, just because I thought maybe it interests you. That is where for one level we do 2 levels RF, and for 2 level disc facial joint we do a 3 level RF. Okay, quickly, I'll just go through quickly. I'll bypass. This is about the C2, we're doing a DRG for the cervicogenic headache, gives a good result, and that is high cervical procedures, and that is how the results are in place. For occipital neuralgia also it gives a good relief, and it can be done from posterior, it can be done from the sidewise, by the way. This is why patient of mine actually who comes and gets this RF machine as a helper. He had a cyst in the C2 oscillating cyst. He could not lie in his bed, he used to sleep sitting. Because of the C2 little masses, oscillating cyst pain, I did one RF and his pain is totally gone. About the disc, with pulse RF, there are good papers, high frequency 60 volt pulse RF does help these patients. but I still go in for bioplasty. I put in those 2 needles, put my frequency probe in there. This is how they look like, then position and did my this. Pulse RF I've done for herpes pain, by the way, not really done for back pain, only herpes pain. Yes, cervical laxation was already there, but the same thing can be going through, and there are stimulating catheters I told you. This is the idea to give you. You can go and stimulate the nerve, find out which is the painful nerve, and can treat accordingly. Same with thoracic pain maps are there. You see all these people getting all these big pain maps around. These are thoracic facial pains. We do intradiscal procedure, thoracic facet, we put needles right in the superior part of the transverse process lateral edge, and we do RF there, and that's where it is done. In closing slides, if there is a mid back pain, sometimes it is to do with the pancreatitis or visceral pain, we should call it, or referred pain is there. We should go in under CT guidance. I did a celiac plexus block. You see those stones right in there. She's a patient chronic pancreatitis and pain relief was miraculous. Ultrasound has come in a big way, and we have so many things showing ultrasound wise. Medial branch, yes, which is very well in cervical area. I was in Toronto this June, and you really see us working on you. It's Gucci, the RF man, I would call it. But yes, working together, it is very brainy together. I want to see thumbs up rather than thumbs down. Well, there's a different perspective. What we think, what surgeons think, being an anesthesiologist, I think I thought I'd rather share with you. Yes, but everything is for the coming generations. Let's do it for our children, grandchildren, more like this. And it's our duty, it's our particular duty. Well, good knowledge in hard work always pays. Let's take it further. Any questions, I'm more than happy to answer. This is the Montreal Congress, World Congress. There was an international summit on pain, and the logo was pain relief is human right. And it's our duty to deliver it. There's going to be a workshop on 26th October. I think people can talk to me later on about this. But this is it. Thank you very much. And sorry for overspeaking. Thank you.
Thank you, Dr. J. Our next topic is on ozone in the management of low back pain.
Good evening, everybody, and greetings from Fortis Memorial Research Institute. I think everybody is enjoying the conference till now, and hoping to see everybody in the banquet today evening. And after seeing such advanced procedures, now we will be turning towards a basic procedure, which is the first and foremost procedure for low back pain which we started. And it is slightly controversial as far as ozone therapy is concerned, as far as specifically considering the indications for ozone, which we are undergoing. And I will be discussing my talk mostly on the ozone discolysis or the intradiscal ozone procedure, which is the basic procedure which we do. Now, low back pain is the most common problem which we come across in our day-to-day activity. And the amazing thing about low back pain is that in 80 to 85% of the cases, it resolves spontaneously within 4 weeks, regardless of the treatment, or even without treatment. So that means that out of 100%, 80 to 85% patients who present to us with back pain, whether we do a conservative treatment or a physical therapy, or the patient doesn't take any treatment, will come back to the normal life in about 4 to 5 weeks' time. But considering this, we should not forget that there are some red flags which we should not overlook, such as a possible fracture, a possible tumor or infection, a bladder bowel dysfunction, a severe or progressive neurological dysfunction in the legs leading to major motor weakness in the quadriceps, plantar flexors, aortas and dorsiflexors. That means neurological signs coming up. So these are the red flags to be looked out before making the patient wait for the back pain to resolve. Now, there are a lot of problems through which the patient can have pain. We can have a degenerative disc, a bulging disc, a herniated disc, a disc degeneration with ossified formation, and multiple of them. Now, this is important as far as ozone is concerned. Now, there are two things. One is a protrusion, the other is an extrusion. Now, what is a protrusion and what is an extrusion? In protrusion, the herniated nucleus or the herniated part has a diameter which is equal to or less than the intradiscal diameter. Whereas in an extrusion, it's opposite. The herniated part has a diameter which is more than the intradiscal diameter.
Now, what are the causes of pain which come across? There is a direct compression of the spinal ganglion, possibly in the intraforaminal or extraforaminal herniation, and a segmental demyelination of involved nerve root, which leads from the compression with resultant conduction abnormalities. So we have a compartment syndrome developing up in the spines with the herniated disc causing the nerve root involvement and the dorsal ganglion involvement. The other mechanism is the immune-mediated inflammatory reaction, which comes up. As we know that normal nucleus is enveloped in a fibrocartilaginous annulus, and when extruded, the immune system recognizes it as non-self, and there is a cell-mediated autoimmune reaction which is triggered, which leads to the production of the enzymes, that is phospholipase A2, prostaglandins, interleukins, which gets elevated and leads to inflammation and pain. Now, as we see in this, can we have a pointer? So, as you see in this, now there is an annular tear in this disc, which is leading to the leakage of the nuclear material from this, causing irritation of the spinal nerve root. So, this is typical of a discogenic pain, in which there is no herniation, but there is an annular tear, which is causing the nuclear material to come out. The nuclear material is recognized as non-self, and there is an inflammation and pain coming up. A similar thing in which we see that the tear coming up, leading to the irritation of the sinovertebral nerves, which are the sinovertebral nerves here. You see this? These are getting irritated with the material, which is the nucleus, phospholipase A2, prostaglandin, nitric oxide, and all the inflammatory materials coming out and leading to inflammation of this, causing a sympathetic pain or a discogenic pain. When this progresses,